Thank you very much, Vanessa. I know it's just a couple of minutes after the hour, and I want to just give people a little bit of time because it's 7 p.m. to start. So I'm going to slowly get into this. So as Vanessa mentioned, I'm a professor of medicine at the University of Manitoba. I've spent my career working in the area of chronic kidney disease. And over time, I've really become more and more upstream. So I started out working on people on dialysis or close to dialysis. And then we started to work in people with late stages of kidney disease who were largely followed by nephrologists. And then I realized that if we really wanted to make a meaningful dent in kidney disease, we had to move upstream and think about primary care, because primary care is where most kidney disease is. And I think nurse practitioners increasingly play a large role in primary care in Canada, which is why I'm really happy to speak today. These are my disclosures. So in kidney disease, we've only moved the needle kind of incrementally in the last 30 years. So from 1970 to 2001, kidney disease is thought about in terms of serum creatinine. And these are American units here, but if you convert them to Canadian units, creatinine of 100 or less than 100 was considered good, 200 was considered bad, and 300 was really bad. And then in 2001, we abandoned creatinine a little bit with good reason, and we started to think about eGFR, or estimated GFR, or kidney function. But here, still thinking in blocks. So greater than 60 is good, 30 to 60 is bad, and less than 30 is worse. In 2012, a heat map came, and some of you may have seen this heat map. It has red, yellow, and green colors. I'll show this in my slides as well. And obviously, green is good, and red is really bad, and yellow and orange is somewhere in the middle. Where I'd like us to be, and how we launched this test, and what we're trying to do, is get us to individual risk prediction, which means calculating the risk for every single person who's with or at risk for CKD, getting to a really precise number for every single individual. And the reason we want to do this is because the patient journey today is largely based on eGFR. So two people with the same eGFR get exactly the same care, despite major differences in their risk of progression to kidney failure or having heart disease. So what that results in is completely non-personalized treatment. So if you're a high-risk patient with kidney disease, you are undertreated and you may crash to dialysis. And if you're a low-risk patient, you may be overtreated. And physicians and nurses don't have accurate tools to look at CKD progression early on, so they just rely on eGFR. And I think even the entire healthcare system, which is burdened, only sometimes thinks about dialysis. And dialysis is a very, very late consequence, but many, many years before dialysis, kidney disease causes heart disease and heart failure hospitalizations, and those are costly and cumbersome, and we need to treat and prevent them. And finally, there are a number of effective medications for chronic kidney disease now. We have a multitude of therapies, which I'll go through, but they don't reach high-risk patients until it's too late. We often start treating patients when GFR is recognizing kidney disease and treating patients when GFR is below 45. And by that time, we can really only delay kidney disease. We can't really stop it or prevent it or put it into remission. And our hope is that a risk-based approach, an approach that looks at each patient through the lens of risk, can transform kidney care. So I broke this talk up into two sections. In the first section, in about 10 to 15 slides, I wanted to give you an overview of the kidney disease clinical practice guidelines. These are global clinical practice guidelines called KDIGO, and there isn't really a Canadian nephrology guideline. Canadian nephrologists follow these KDIGO guidelines. So what I'm telling you is essentially also consistent with how Canadian nephrologists think about and look after chronic kidney disease. So let's start. So first, what's the definition? So the definition is still based on C, G, and A. Okay, so C for cause, G for GFR, and A for albuminuria. And what's really important here is that we sometimes think about cause. We always think about eGFR, but we often don't think about albuminuria. And we wanted to really provide the CGA as a reminder that you must think about albuminuria and cause and not just think about eGFR. And this is that heat map that I was talking about. So as you can see in the heat map, there's G stages for GFR, A stages for albuminuria, and the colors go down the diagonal. So you can go from green to orange, whether you're either through the GFR route or through the albuminuria route. And in fact, if both are bad, you go diagonal and you become red very quickly. So this slide really shows that both GFR and albuminuria are equally important, and progression going anywhere from green to yellow or yellow to orange or orange to red is associated with a higher risk of all-cause death, cardiovascular death, acute kidney injury, or kidney failure requiring dialysis. The screening algorithm for kidney disease requires also both GFR and ACR. So how do you screen and how do you diagnose? Well, you start out by looking for an eGFR that's less than 60 and or an ACR greater than 3 in Canadian units. So if the eGFR is less than 60 or ACR is greater than 3, after 3 months, it has to be repeated at least once. And if on a repeat it's still GFR is still low or ACR is still high, that person has kidney disease. And the guidelines also acknowledge that if you can, you should measure both creatinine and a new marker of kidney function called cystatin C. Now, cystatin C is a more accurate marker of kidney function than creatinine for a lot of people, and it is available through Life Labs, but it's not widely covered yet or available outside of in wide settings, and we are increasingly making efforts to use this. I'll spend a slide on cystatin C and talking about some of the potential benefits. So what we want to do is stage according to GFR and ACR. We want to look for the cause, estimate the risk of progression, and then initiate treatment. And if the GFR is greater than 60 and the ACR is less than 3 and there's no other markers, there's no kidney disease. So let's talk about cystatin C. So we've always used creatinine to estimate kidney function, and creatinine is a waste product of muscle. And so anything that affects muscle or protein intake can really affect creatinine. So people who are really muscular or people who are really frail will tend to have higher and lower creatinines respectively. People who eat a lot of protein, as many of your patients probably do, and people who eat very little protein will have higher and lower creatinines, even with the same level of kidney function. So when possible, if you could combine it with this other test called cystatin C, together, the two tests lead to a better measurement of kidney function. So the way the guidelines say is that they recommend an initial test of serum creatinine, but in patients with an amputation, a spinal cord injury, malnutrition, heart failure, liver disease, either really high muscle mass or really low muscle mass or really high protein intake or really low protein intake, they recommend using cystatin C in addition to creatinine. And if you still want more accurate measurements, you can do a nuclear medicine test for GFR, but for most people, this is not necessary. The other thing to note is that eGFR and ACR should be, how often should you measure it? So this is a common question in practice. You know, first, should I just keep track of someone's eGFR? I would say if someone has kidney disease, you should check it, you should follow this chart, and you should check it 2, 3, or 4 times a year, both eGFR and ACR, depending on where they fall in the red, yellow, or orange or green. Now, green refers to people who do not have kidney disease, and that's the screening scenario. And that means that in people with diabetes, high blood pressure, or heart disease, we check eGFR and ACR once a year. The other thing we want to note is that eGFR can change 20% from visit to visit, and even up to 30% when you start an ACE inhibitor, an ARB, or an SGLT2 inhibitor, or finerenone. And I'll get into all of these drugs. So drops in eGFR of less than 20%, if the patient is doing well, we should not be concerned. What that means is if someone's eGFR is 50 today, It could be 41 or 59 tomorrow, and that's within the realm of normal change. So if the patient is doing fine, we generally don't need to react, okay? Similarly, albuminuria can double or half even within day-to-day variation. So we try to give a message to treat kidney disease and risk stratify, but don't pay attention to small variability in individual labs. Think about the longer term. Now, how do you manage and treat kidney disease? Well, the way to treat it is to target both kidney disease indirectly by targeting its drivers, which are hypertension and diabetes, and to also use therapies that slow the decline of eGFR and reduce albuminuria. So you have to do both the indirect things and the direct things. And the first step, of course, is lifestyle. So the guidelines do recommend a balanced diet, and there is some data that a plant-based diet and a lower consumption of ultra-processed foods likely leads to better kidney function, or at least better control of the complications of kidney disease. So what does that mean for the patients in front of me? So for my patients with kidney disease, I often just tell them, when they ask, patients always want to know, what can I do in my diet to help? And I always tell them, consider adding more fruits and vegetables to your diet, and try to cook more at home, which all of those things lead to less ultra-processed foods and more plants, and I think that's good for most people. What about blood pressure control? So we recommend in the kidney disease guidelines for people with kidney disease a blood pressure of less than 120 using a standardized BP. Now, what's a standardized BP? A standardized BP is someone coming into the office, sitting down calmly without someone else in the room for a few minutes, and having 5 measurements taken where the top and the bottom measurement are gone and the middle 3 are used. A home blood pressure of 120 is also useful, but certainly I would recommend office blood pressure at least in the 120s if you cannot do a standardized as a target. People with kidney disease, when they achieve these lower goals, tend to do better. We also believe that unless somebody has hyperkalemia, so unless their potassium is really high, like 5.5 and higher, it's better not to restrict their potassium. Again, diet is often important for patients. So what I would suggest is that let them eat the fruits and vegetables and high potassium foods that may be helping. They're already restricted because of diabetes and hypertension often, and don't restrict unless that's not warranted. So that's the diet and lifestyle piece. Now let's get into some of the treatments. So pharmacotherapy is a cornerstone for treating kidney disease and preventing its progression to dialysis. The way I think of treatment of kidney disease, I think of it like a pyramid. And at the base of the pyramid is these 2 medications called RAS inhibitors and SGLT2 inhibitors. So almost everybody with kidney disease should be on a RAS and SGLT2 inhibitor. And we should be doing the highest approved and tolerated dose for the RAS inhibitors, and we should not stop it unless there's a big change in creatinine of more than 30%. With an SGLT2 inhibitor, is the same thing. They tend to benefit people with or without diabetes, and unless they have type 1 diabetes, I tend to keep people on SGLT2 inhibitors. In my practice, the only reason people largely stop SGLT2 inhibitors is because of recurrent yeast infections. So there are 3 major trials of SGLT2 inhibitors that show this, and these drugs are pretty amazing. So they slow the progression of kidney disease by 30 to 40%. They also prevent heart failures, and this happens again with or without diabetes. So whether kidney disease is from diabetes or without or not from diabetes, SGLT2 inhibitors can be incredibly helpful. So what to do next? So now you have the base of the pyramid, which is RAS and SGLT2. You can add on. So the question is what to add on for patients who still have risk. And I'm going to spend the second half of this talk talking about how to identify that risk. But for patients who still are intermediate or high risk, despite RAS and SGLT2, they may benefit from a non-steroidal MRA, and an example of this drug is finerenone, or a GLP-1 like semaglutide or Ozempic. And these drugs have now been proven in people with diabetes and kidney disease. Finerenone, it causes less hyperkalemia than spironolactone, and it's indicated for people with diabetes and an eGFR greater than 25 who have albuminuria, despite RAS and SGLT2. And semaglutide or Ozempic, which you know quite well, is also shown to be beneficial, and it prevents kidney disease progression, prevents heart failure, and prevents cardiovascular death in people with chronic kidney disease and diabetes. So in fact, we have four pillars, right? So you've got RAS, SGLT2, non-steroidal MRA, GLP-1. So you have people with diabetes, people with high blood pressure, people with chronic kidney disease, and you cannot seriously tell every patient in front of you to get on 4 drugs, right? It seems a bit crazy. So I think we need a better way, a more personalized way to prescribe medicine. And that's where risk prediction comes in. So the guidelines very quickly say that this heat map, this red, yellow, green approach only reflects the risk at a population level. That within each box, there's a lot of variability. So there's a whole bunch of people in this orange box that are actually lower risk than some of the people in the yellow box, and the red and the yellow, and the orange and the yellow. So there's a lot of mixing. And you can get to the precise risk for each person by using a prediction equation. And the guidelines recommend the use of externally validated. So what does that mean? The guidelines say that you should, an equation that's built in one population and then tested in another independent population should be used. So some of you may be familiar with this equation we built called the kidney failure risk equation, or the KFRE. It's available online at kidneyfailurerisk.com, and it's also routinely reported in Ontario whenever an eGFR is less than 60 and you order urine ACR. So the step 1 is to order urine albumin to creatinine ratio. Order the urine ACR, and if the eGFR is less than 60, you'll see this dialysis risk. So we built this equation using age, sex, GFR, and ACR. It's been now shown to be accurate in more than 4 million people, and it's used by more than 200,000 healthcare providers worldwide. And it's part of global guidelines. So this is for late stages of kidney disease. So when GFR is already less than 60 and usually less than 45. We're exactly at the halfway point. So I want to talk now about acting early, okay? So here's a case of somebody who's got very high-risk kidney disease, and we start 3 treatments, RAS, SGLT2, and finerenone, when their GFR is 80. It turns out we can save that patient 29 years of dialysis by starting treatment early. And in fact, we can reduce their heart failure hospitalization risk by 65%. So we get to avoid dialysis, avoid transplant, reduce cardiovascular risk, and halt CKD progression. You can mimic this scenario on this site we built called actearlyonkidney.com. You can select a patient's risk of progression. So like here's an intermediate risk scenario, same 3 treatments, and acting early versus acting late. And you can see if a patient is intermediate risk, you actually prevent a lifetime of dialysis. So with a single therapy, the patient is on dialysis at 64. With triple therapy, they never get there. So early intervention is incredibly powerful in kidney disease. And the reason it doesn't happen, despite our best intentions, is because there are major challenges in delivering it. In fact, there are gaps in care that prevent the right actions. So what are the 3 key gaps? First, you need to order the right tests, right? So what happens in practice? We do annual labs. We're concerned about kidney disease, but we just order an eGFR or a creatinine. We don't order a urine or a urine ACR. Second, the tests need to be interpreted appropriately. So let's say the urine ACR is abnormal, but the eGFR or creatinine is normal. 8 times out of 10, that ACR is then ignored because we think that if the eGFR or creatinine is normal, there's no kidney disease. And finally, even if we recognize that the ACR is abnormal and we just only start the patient on RAS inhibitor, as you can see, we lose that opportunity to prevent lifetime risk by adding double or triple therapy if that patient is high risk. So because of these 3 key gaps, very few patients actually get the right care. And what we've tried to do is create a test here that resolves all three key gaps in care. The Klinrisk test or test panel includes an EGFR, an ACR, a chemistry, and a CBC. So when you order the Klinrisk panel, the patient is guaranteed to get the EGFR, the ACR, the chemistry, and the CBC. Step 2, we give you interpretation that the patient is low, intermediate, or high risk. So there's no chance that the results get misinterpreted. And finally, we link the patient's labs to the practice guidelines and give you guideline-based actions. I'm going to show you all of this. But really what we want to do is provide personalized decision support. So that's what you need to close all three key gaps in care. So now let me go through how we built the test and how you can use it in your practice. So first, we wanted to build a test for all stages of kidney disease. For people without kidney disease, including people with diabetes and hypertension, and people with normal GFR or normal kidney function. So we wanted to cover screening, diagnosis, and prognosis in one test. So what we wanted to predict was not dialysis, because dialysis is too late. We wanted to predict 40% decline in EGFR. Now 40% is really extreme. That means somebody's EGFR goes from 100 to 60 or 80 to 48 in 5 years. It shouldn't happen, right? And we built this test using routinely collected lab data. It's just a CBC, a chemistry panel, no biomarkers, no special tests. Really, it's a model for everyone. And it's very widely validated. So we built the test in 77,000 people in Manitoba. We then tested it in 100,000 people in Alberta. Then we tested it in 27,000 people from 2 different clinical trials. And since then, 5.7 million in 2 separate US studies that we published in the last year. So in total, this model has been tested in 5.8 million adults, making it the most widely validated model in kidney disease. We showed first that if you just use EGFR and ACR, you're much less accurate than this model. So 74 to 79% accuracy versus 81 to 85% accuracy at 1 and 2 years. We also showed that there's 30-fold separation in risk between high and low risk group in this clinical trial data set of SGLT2 inhibitors. Not only did we show that there's this big separation, we also showed that when you treat somebody with an SGLT2, which is an effective drug, that their risk goes down. And if you treat them with placebo, their risk goes up. And within 6 months, you know that your treatment is effective. I wanted to show this slide to give you the example of a population. So if you have 1,000 people in front of you in your practice, and if they have kidney disease with or without diabetes, if you treat all of them with SGLT2, all 1,000, you'll prevent 11 kidney disease progression events, 11 cardiovascular death events, and 4 acute kidney injury events in 1 year in people with diabetes, okay? So what that means is that you will need to treat 32 to 46 people every year to prevent 1 event. That's really good, actually. I think that's a good thing to do. But if you order the Klinrisk test and you find a high-risk person, you only need to treat 5 high-risk people to prevent 1 event. So it really concentrates and focuses the energy and removes the debate. So the other thing I find really useful about it is that when a patient learns that they're high risk, they become much more receptive to the treatment. So it also removes the debate in the office about starting another medication. You can also go show the patient that a high-risk patient slope of rate of kidney function decline or slope of kidney function decline goes from -6 to -3 with drug, giving them a net benefit of 3% per year. An intermediate risk patient gets a net benefit of 2 mils per minute per year, and a low risk patient gets a benefit of 1 mil per minute per year. So it's really, again, trying to get at this notion that the bigger the risk, the more the benefit, the more imperative it is to start and maintain therapy. In this 1 million person study, we also showed that your risk calculated today leads to a bad prognosis even 15 years later. So a single lab test, a CBC, a chemistry, a urine ACR, which we use to calculate the Klinrisk score, was valid even out to 15 years. These red line, the high-risk people, half of them had lost the majority of their kidney function 15 years out, compared to less than 20% in the green and less than 5% in the blue category. They were 10 times more likely to lose kidney function over a decade, and that's remarkably high. The one other thing we really wanted to highlight in this 1 million person study was that we don't really see risk without ordering the test, okay? So if physicians often tell me sometimes, I don't need a risk score, I know who's high risk. But actually, when you look at practice, high risk patients are less likely to receive SGLT2 inhibitors, less likely to receive GLP-1 compared to low risk patients, and similarly likely as intermediate risk to receive ACE and ARB. So why is that? Why are high risk patients getting inferior treatment? I think that it's because high risk patients' kidney function goes down quickly and fluctuates more. And so what happens is the creatinine fluctuates and people stop long-term therapies, which may be beneficial. So what's important about knowing high-risk status is that you can also maintain therapy for longer. So if you know someone's high risk or intermediate risk, you're more likely to keep them on treatment and not react to the small bumps. In our largest study of 4.6 million people, we showed again that the model was accurate. But not only does it predict kidney disease progression, it predicts all-cause costs, and it predicts hospital visits and ER visits. In fact, patients who are high risk tend to have 10 times more ER visits and 5 times more hospital visits than low-risk patients. And it's not, you cannot figure that out based on their rate at the beginning. So at the beginning, it's 13 and 10, 16 and 12 between low and high risk groups. And towards the end, it's 14 and 4 or 25 and 7. So previous ER visits do not predict future ER visits as well as risk-based care. So what drives it in these patients? Well, what drives hospitalizations in people with kidney disease is kidney disease and heart failure. It's not stroke, it's not MI, it's not peripheral arterial disease. And that's true in Japan, in Sweden, in the US, in Canada. And the nice thing is that all the therapies for kidney disease, like RAS inhibitors, SGLT2 inhibitors, finerenone, Ozempic, they all treat both kidney disease and heart failure. So when you treat a high-risk patient, you in fact treat both conditions. So remember when I said not everybody needs 4 drugs. So this is how I see it. If you're low risk, so risk stratify everybody. If you're low risk, you get RAS and SGLT2. If you're intermediate risk, you get 3 drugs. Now, if you're obese, you get a GLP-1. If you don't want an injection and you're non-obese, you get a finerenone or a non-steroidal MRA. And if you're very high or high risk, you probably need all 4 medications because your risk is so high and there's such a big benefit to treatment. So now, in the last 5 to 7 minutes, let's talk about how we enable all of this. How does all of this actually happen? So the way we enable it is by ordering a panel called the Klinrisk panel instead of ordering individual tests. So if you select Klinrisk on your LifeLabs requisition, your patient goes to LifeLabs just like they normally do, and they drop off blood and urine. Those lab results come to us, and we provide you a complete personalized risk assessment and a guideline-directed care plan. Essentially, there's no extra steps, and we're trying to simulate a full nephrology consult. And this is what the report looks like. So on the one corner, you have the patient's risk. So this is 60%. 60% of the circle is red. And you can see 60 out of the 100 stick figures are red. So it's very clear. And in the middle, front and center, is everything that needs to be done for this patient. What should be the frequency of monitoring? How often do you need to see them? What should be their blood pressure target? Do they need a nephrologist? What complications of kidney disease do they have present? And what therapies do they need, like RAS inhibitors, SGLT2 inhibitors, MRAs, Ozempic? What's needed to slow kidney disease progression? We have incredible data that shows that when you alert providers to this, when you show them this report, good things happen. we demonstrated that in a study of 20,000 patients and 40 providers, that highlighting risk resulted in 90% increase in ACR testing, 40% increase in RAS inhibitor use, 200% increase in SGLT2 use, and an 80% increase in MRA use. This is all done within a 2-year time span. So we saw a tripling and a doubling of effective therapy in 1 to 2 years by showing providers the risk. So to put this all together, the Klinrisk test can help identify patients at elevated risk much earlier so that healthcare professionals can prevent the decline. So we want to act before the decline in kidney disease happens. Now the test is available, as I mentioned, through LifeLabs, and it's completely HSA reimbursable. So your patient, it's a private pay test, but the patient can then get reimbursed if they have a healthcare spending account. Ultimately, I think testing and sharing these results and reports with patients, and patients receive their test if they have their LifeLabs MyCare Compass or MyCare portal, it allows for shared decision-making. And shared decision-making is essential so that the patient actually accepts and follows their treatment plan. It allows you to do timely medication reviews, patient-centered management, and it allows you to pick and choose what therapies you want to. These patients are on a lot of treatments, and this allows you to have a really nuanced discussion about why you're starting 2 or 3 or 4 drugs and why kidney disease is so important for the person in front of you. So this is my last slide. I think what I want to tell you and leave you with is I'm a nephrologist, but the best time to intervene in kidney disease is before me. It's well before the nephrologist. And yes, GFR and albuminuria are essential for staging. They're both very important, but that's only the beginning. Risk stratification can help you take kidney care to the next level. And so we've developed this test panel to complete all the gaps in care. And what we're trying to achieve is to get high-risk patients, high-intensity therapy. We want personalized medicine where the treatment matches the risk of the patient. If you imagine, this has been going on in oncology forever, right? People who have a more aggressive cancer get more aggressive chemotherapy. People who have a very benign cancer get more benign therapy. We need this paradigm in kidney and cardiovascular diseases. Everybody is not the same. And finally, I think I've seen this play out in my exam room many times, sharing this prognostic info, sharing this report, sharing these resources with the patient removes clinical inertia. It actually engages the patient to participate in their care plan. And together, you can work on not just getting on, but also staying on treatments. These treatments are now more affordable than ever. Many of them are generic or becoming generic. So it's really much more about not missing the gaps. So with that, I'll end, and thank you for your time and attention.
Thank you so much, Dr. Tangri. And let's see if there's a question there for you.
Yeah, it's an excellent question from Ariane. Yes, I think this is certainly the goal for LifeLabs and for Klinrisk. There's quite a long process for tests to become diagnostic tests to become publicly funded. So I'll share a story about some diagnostic tests that have been around almost for 2 decades. So like cystatin C, NT-proBNP, or lipoprotein A, right? And it's not like drugs where you could just go to CADIT and present your case. So first there needs to be some volumes. And then once the volumes come up a little bit, then private insurance tends to take it up, and then public insurance. So currently the test is HSA reimbursable, but what we're working towards is eventually getting enough volume so that all private payers cover it even outside of HSA. The other thing I want to highlight is that we continue to work with partners to have sponsored or free testing periods. So I think if we're able to contact you and others through the NPAO, we can certainly, LifeLabs can alert you when there's a next free testing period. We anticipate there'll be one in 2026, in early 2026, where you can take it, or you and your patients can take advantage of those free sponsored testing periods. Ultimately, certainly our goal to remove all barriers to testing and get public reimbursement. Thank you.
That's great. Thank you so much for taking the time, and thank you those that joined us today. This session is recorded and will be again archived on the NPO website. So thank you and have a
Thank
great
you.
evening.
Thank you. Bye bye.
Bye bye.